I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. This is episode 5 of our 8-part series on menopausal hormone therapy. So far, we have explored what happens during perimenopause and menopause, what MHT can and cannot treat, the different ways estrogen can be delivered, and the role of progesterone and progestogens in protecting the endometrium. Throughout this series, we have occasionally imagined the reproductive hormones as members of a very successful girl band. Estrogen is Beyoncé, the headline act, and the hormone most people immediately associate with menopause. Progesterone is Adele, perhaps quieter, but essential when she is needed. And testosterone is, of course, Pink. She may not always be centre stage, but she brings drive, energy, and intensity to the performance. It is a memorable analogy, but today we need to be clinically precise. Testosterone is not a universal treatment for fatigue, weight gain, brain fog, low mood, or loss of confidence. Its evidence-based role in menopause care is much narrower. In this episode, we will look at what testosterone does in women, what happens to testosterone around menopause, who may benefit from treatment, how it is prescribed and monitored, and where the enthusiasm has moved beyond the evidence. Testosterone is often described as the male sex hormone, but women naturally produce testosterone too. Before menopause, it is produced by the ovaries and adrenal glands, and through the peripheral conversion of androgen precursors. Circulating concentrations are much lower than in men, but testosterone remains part of normal female physiology. It contributes to sexual desire, arousal, and responsiveness. It may also play physiological roles in muscle, bone, mood, and cognition, but that does not mean giving more testosterone will improve every symptom associated with these systems. Fatigue, low mood, poor motivation, reduced libido, and difficulty building muscle are not specific to testosterone deficiency. They may also reflect poor sleep, vasomotor symptoms, depression, anxiety, thyroid disease, iron deficiency, chronic pain, medication effects, relationship difficulties, or the demands of midlife. There is no recognized collection of non-specific symptoms that diagnoses a general female testosterone deficiency syndrome. What happens around menopause? Estrogen can fluctuate dramatically during perimenopause and then remain consistently low after menopause. Testosterone behaves differently. Levels generally decline gradually across adult life, rather than dropping abruptly at the final menstrual period. The important exception is surgical menopause. When both ovaries are removed, ovarian production of estrogen, progesterone, and testosterone is lost suddenly. This can produce a more abrupt hormonal transition and may be particularly relevant when assessing a sudden change in sexual desire. A low testosterone result in women cannot be interpreted in the same way as testosterone deficiency in a man. There is no single blood concentration below which we can reliably say that a woman's symptoms are caused by insufficient testosterone. Blood testing has a role in safe prescribing and monitoring, but it does not diagnose hypoactive sexual desire disorder. What is testosterone actually indicated for? This is the most important point of the episode. The only established evidence-based indication for systemic testosterone therapy in women is hypoactive sexual desire disorder, or HSDD, primarily in postmenopausal women following a comprehensive biopsychosocial assessment. HSDD is not simply having less sex than a partner would prefer, and it's not having less spontaneous desire than someone had at 25. And it's not automatically diagnosed because a woman says, "I'm tired and I'm not interested in sex at the moment." Sexual desire varies greatly between people and across different stages of life. HSDD involves a persistent or recurrent reduction in sexual desire that causes clinically significant personal distress and is not better explained by another medical condition, medicine, relationship issue, or psychosocial factor. The distress component matters. A woman may have very little spontaneous desire and feel entirely comfortable with that. Another may feel deeply distressed by a loss of desire and its effect on her sense of self, well-being, or relationship. That experience deserves to be taken seriously. In Australia, AndroFeme 1 is TGA approved for the treatment of HSDD in postmenopausal women. The biopsychosocial assessment. Before prescribing testosterone, clinicians need to look beyond a laboratory result. Sexual desire is influenced by biology, psychology, relationships, culture, opportunity, and context. Biological factors may include vaginal dryness, vulvovaginal discomfort, pelvic floor dysfunction, pain during sex, vasomotor symptoms, fatigue, sleep disruption, depression, chronic illness, and medication effects. SSRIs and SNRIs may reduce desire, arousal, or the ability to reach orgasm. Antipsychotics, opiates, and some antihypertensives may also affect sexual function. Psychological factors may include anxiety, depression, negative body image, previous trauma, fear of pain or stress. Relationship and contextual factors may include conflict, lack of emotional connection, unequal household labor, caring responsibilities, a partner's health, mismatched desire, or lack of time and energy. This does not mean that sexual concerns should be dismissed as all in her head or blamed on a relationship. It means testosterone should not be expected to solve problems that testosterone did not cause. A useful clinical question is not only, do you have low desire? It is also, is the loss of desire distressing to you? We might then ask, has desire changed from what is normal for you? Is there pain or vaginal dryness? Can you become aroused once sexual activity begins? Are you able to reach orgasm? Is the concern present in all situations? What medicine are you taking? How are you sleeping? What else was happening when the change began? These questions help distinguish distressing low desire from broader sexual dysfunction and identify factors that may be treated without testosterone. Estrogen may need attention first. For many women, sexual difficulties are partly driven by estrogen deficiency. Vaginal dryness, burning, reduced lubrication, and pain can make sexual activity unappealing. It is hardly surprising that desire may fall when the body has learned that sex is likely to hurt. Genitourinary syndrome of menopause may require vaginal estrogen, systemic MHT, moisturizers, lubricants, or another targeted management. Vasomotor symptoms and sleep disruption should also be addressed. A woman who is waking repeatedly with night sweats and struggling through the following day may not primarily have a testosterone problem. And this is why clinicians should optimize treatment of other menopausal symptoms and address modifiable causes of sexual dysfunction before or alongside considering testosterone. What benefit should patients expect? Testosterone is not a switch that turns libido back on overnight. In appropriately selected postmenopausal women with HSDD, physiological dose transdermal testosterone produces a moderate average improvement in sexual desire and other aspects of sexual function. Trials have reported improvements in desire, arousal, orgasmic function, pleasure, and sexual responsiveness, together with reduced distress related to low desire. Some analysis found an average increase of about 1 additional satisfying sexual event per month compared with placebo. That can sound underwhelming when stated without context, but averages do not show the range of individual responses. For a woman who has experienced sustained and distressing loss of sexual interest, an improvement in desire, responsiveness, and connection may be highly meaningful. However, treatment should not be presented as a promise to restore someone to exactly how she felt decades earlier. Sexual well-being is not measured only by frequency. Before treatment begins, it's helpful to define what improvement would actually look like. Would it mean thinking about sex again, feeling more receptive to intimacy, becoming aroused more easily, feeling less distressed by the loss of desire, A clear baseline helps the clinician and patient decide whether treatment has genuinely helped. Some women may notice a change within 4 to 8 weeks, but maximal benefit can take several months. If there is no meaningful benefit after an adequate trial, generally around 6 months, treatment should be stopped. Prescribing testosterone in Australia. Australia has a testosterone formulation specifically approved for women. AndroFeme 1 is a 1% testosterone cream. The usual starting dose is 5 milligrams of testosterone, supplied in 0.5 milliliters of cream, applied once daily to the upper outer thigh or lower buttock. The distinction between milligrams and milliliters is important. The patient applies 0.5 milliliters of cream, which contains 5 milligrams of testosterone. The cream is measured using the supplied applicator. It should be applied to clean, dry skin and allowed to absorb. The patient should wash her hands after application. Skin-to-skin transfer should be avoided until the site is dry, and patients should follow the product instructions regarding washing the area and contact with partners, children, or pets. It should not be applied to the breasts, vulva, or vagina. This is systemic therapy delivered through the skin. It is not a vaginal treatment for genitourinary syndrome of menopause. Testosterone products designed for men contain doses intended to produce male concentrations. They should not be used in women at standard male doses. Why transdermal therapy? Transdermal testosterone is preferred because it can achieve physiological female concentrations while avoiding some of the hepatic and lipid effects associated with oral testosterone. Oral testosterone formulations can adversely affect lipid profiles and are generally not recommended. Injections and pellets can produce supraphysiological concentrations and may be difficult to reverse quickly if adverse effects occur. Once a pellet is implanted, the dose cannot be easily reduced or removed, and excessive concentrations may persist. Compounded bioidentical testosterone is also generally not preferred when an approved product is available because potency, absorption, and quality may vary. Blood testing and monitoring. Testosterone blood testing is important, but not because it confirms HSDD. A baseline concentration does not tell us whether a woman's low desire is caused by low testosterone, and there is no cutoff that reliably predicts who will respond. Testing is used mainly to identify unexpected high baseline concentrations and to reduce the risk of supraphysiological exposure during treatment. A baseline total testosterone level is usually obtained before therapy. Sex hormone binding globulin, or SHBG, may also be useful. SHBG binds testosterone. When SHBG is high, a smaller proportion is available as free or bioavailable hormone. Oral estrogen can increase SHBG through its first-pass hepatic effect. Thyroid replacement and other factors may also influence it. However, clinicians should not simply increase the testosterone dose to overcome high SHBG, as this may create excessive exposure and androgenic adverse effects. Testosterone should be rechecked after treatment begins and after dose changes. Once the dose is stable, periodic monitoring, often every 6 to 12 months, helps ensure the concentrations remain within the physiological pre-menopausal female range. The aim is not to reach the upper end of the range, and the aim is not to treat a single numerical target, and it is certainly not to achieve male testosterone concentrations. Results should be interpreted alongside clinical benefit and adverse effects. If the level is well above female physiological range, the dose should be reduced even if the patient feels well. Adverse effects. At physiological female doses, transdermal testosterone is generally well tolerated in the short term. The most common adverse effects are androgenic, including acne and increased facial or body hair. Some women may notice scalp hair thinning, particularly if they are genetically susceptible to androgen-related hair loss. More severe effects such as voice deepening, clitoral enlargement, and marked hirsutism appear uncommon at appropriate doses, but the risk increases with supraphysiological exposure or poor monitoring. Some viralizing changes may be irreversible. Patients should report new or worsening acne, coarse facial hair, scalp loss, voice changes, or genital changes. The application site should also be checked for irritation or local hair growth. Breast and cardiovascular safety. Short-term trial data are reassuring when testosterone is used transdermally at physiological female doses. However, the limits of the evidence need to be stated clearly. Randomized trials are not sufficient to establish long-term breast cancer or cardiovascular risk safety beyond several years. Many studies excluded women with significant cardiometabolic risk, which limits how confidently the findings can be applied to every patient. Short-term reassurance is not the same as proof of long-term safety. Women with a history of hormone-sensitive cancer, significant liver disease, unexplained androgen excess, or complex cardiovascular risk require individualized specialist consideration. Testosterone should not be used during pregnancy. What testosterone has not been approved to treat? Testosterone is increasingly promoted for fatigue, brain fog, low mood, poor motivation, weight gain, reduced muscle mass, osteoporosis prevention, dementia prevention, cardiovascular prevention, and general anti-aging. At present, there is insufficient evidence to recommend testosterone for these purposes. It should not be prescribed as a general treatment for fatigue or brain fog. Trials have not established that physiological female testosterone therapy meaningfully prevents fractures, produces clinically important gains in muscle function, prevents dementia, or protects against cardiovascular disease. Some women report feeling more energetic or confident after starting testosterone. Those experiences should not be dismissed, but they do not establish testosterone as a treatment for fatigue, depression, cognition, or weight management. Pink may be an important member of the band, but she's not responsible for every part of the show. Spontaneous and responsive desire. It can also help to distinguish spontaneous from responsive desire. Spontaneous desire appears without an obvious prompt. Someone thinks about sex and wants to initiate it. Responsive desire emerges after intimacy, touch, emotional connection, or sexual activity has begun. Many people assume healthy desire must always be spontaneous, but responsive desire is common, particularly in long-term relationships and during midlife. A woman may rarely think about sex unprompted, but still enjoy intimacy and become aroused once it begins. This is not necessarily HSDD. The key questions are whether the pattern represents a distressing change and whether she retains the capacity to experience pleasure and responsiveness. This distinction can prevent normal variation from being unnecessarily medicalized. Responsive desire does not mean anyone should participate in unwanted sexual activity. Consent, comfort, safety, and autonomy remain central. The pharmacist's role. The pharmacist can play an important role in safe testosterone use. We can reinforce the indication and help set realistic expectations. We can check the product and dose carefully, remembering that male and female testosterone preparations differ substantially in strength and delivery. We can explain application technique, hand washing, drying time, storage, and transfer precautions. We can ask about baseline testing, follow-up monitoring, and androgenic adverse effects. And we can make space for sexual health conversations without embarrassment or judgment. Sexual well-being is a legitimate health concern. Women should not have to describe themselves as broken, unfeminine, or failing in their relationship before clinicians take distressing loss of desire seriously. At the same time, testosterone should not be framed as the hormone that makes a woman energetic, youthful, sexy, or complete. Good menopause care makes room for nuance. Bringing the band together. So where does Pink fit alongside Adele and Beyoncé? Estrogen remains the main hormonal treatment for vasomotor symptoms and many other menopausal symptoms. Progesterone or a progestogen is required for endometrial protection when systemic estrogen is used by someone with uterus. Testosterone plays a more specialized role. It is not automatically the third component of every MHT regimen, and not every woman taking estrogen and progesterone needs it. But for a carefully assessed postmenopausal woman with persistent, distressingly low sexual desire that is not adequately explained by modifiable factors, physiological dose transdermal testosterone may provide meaningful benefit. Testosterone should neither be dismissed as unnecessary nor promoted as a universal missing hormone. It is an evidence-based treatment for a specific clinical problem. Some reflective questions. How would you distinguish normal variation in sexual desire from hypoactive sexual desire disorder? Which biological, psychological, medication-related, and relationship factors should be assessed before testosterone is prescribed? Why can a serum testosterone concentration not diagnose HSDD? What is the approved indication and usual starting dose of AndroFeme 1 in Australia? What counselling should be provided about application, hand washing, and skin-to-skin transfer? Which adverse effects may indicate excessive androgen exposure? How would you respond to a patient who has been told testosterone will treat fatigue, brain fog, and weight gain? When should treatment benefit be reviewed, and when should testosterone be stopped? In the next episode, we will focus on vaginal estrogen and genitourinary syndrome of menopause, or GSM. We will look at the vaginal, vulval, and urinary symptoms caused by estrogen deficiency, why GSM often becomes more troublesome over time, and how local vaginal estrogen differs from systemic MHT in its absorption, safety, and clinical use. Until then, keep questioning, keep learning, and remember, not every member of the band needs to sing on every track, but sometimes the treatment needs to be delivered directly to the part of the stage that needs it most.